male has presented to the emergency department with the features of subacute intestinal obstruction. There is an history of recurrent episodes of abdominal pain, hot flushes, diarrhea after having meals, and breathing difficulty from the past 3 months, and the patient has lost 6 kgs. On evaluation, his CECT showed subacute intestinal obstruction, and the cutoff point was at the distal ileum. And the cause for the obstruction couldn't be made out. During exploratory laparotomy, the affected bowel segment, it showed a large mesenteric nodal mass with intense fibrosis of the mesentery, showed small submucosal mass which appeared yellow in cut surface. So this is the question. So first I'll read out the first subdivision of this clinical scenario. So diagnose this case and how will you evaluate this patient? Your time starts now.
Ma'am, this is a case of distal ileal gist, ma'am.
Okay. That is your answer. So what made you to think that this is a gist?
Ma'am, firstly, the submucosal, the intense fibrotic reaction, that is one point. And second, the subacute intestinal obstruction that it is causing in the
Okay.
distal ileum, and the yellowish color of the submucosa, the color of that mass, basically.
Okay. The answer is grossly wrong. So I'll pass the question to the next person. That is Venu.
I think this is about small bowel neuroendocrine tumor, like
Yeah.
carcinoids.
You want to justify the diagnosis just for the sake of others?
Carcinoids syndrome, ma'am. Carcinoid syndrome.
Yeah, it's a case of carcinoid syndrome. Very good. That's
Yes, ma'am.
the right answer. And how will you evaluate the patient? You want to add any additional points? Why do you call it as carcinoid syndrome? Like now
Because
from the history, from the laparotomy findings, why do you think it's carcinoid?
because of flushing and symptoms are present, flushing, diarrhea.
Yeah. That is
That's
there in
why.
the history. What about the laparotomy finding? This is just an additional question. Don't get worried. Your
Okay.
marks are given since you said
Yeah.
it is a neuroendocrine tumor.
Yes.
Yeah.
Intense fibrosis.
Yes.
Like
That intense fibrosis is a typical feature of neuroendocrine tumors. They'll cause severe infiltration into the muscularis propria, into
yes,
the mesentery. They'll cause desmoplastic reaction in
yes,
the mesentery, which will cause kinking of the bowel. That is the main reason why patients present with obstruction.
subacute obstruction.
Yeah. No neuroendocrine tumors will come as straightforward cases. Usually they'll present as obstruction. Okay. And
Yes.
this patient also had carcinoid syndrome. So that's the right diagnosis. So how will you evaluate this patient?
First, we can by confirmation by the blood investigations.
Yes.
Then radiological investigations.
Very good. So
Then
what is the
operable.
radiological investigation you want to do?
CCT abdomen is the CCT abdomen and chest for the CCT abdomen, ma'am. I think first.
Since it's a neuroendocrine tumor, anything else in the imaging?
Upper lower G endoscopy, something upper G endoscopy means lower G endoscopy and distal ileum.
Oh, anything else? To evaluate
PET
this
CT.
particular patient? Yes.
PET.
PET CT. Anything you want to add to the PET CT?
Missed like stomatocyte receptor agonist, like.
Very good. So you want to do some kind of radionuclide
Yes, ma'am.
based PET CT.
Yes.
Okay. Yeah, I'll give you the points, but do you want to specify which radionuclide investigation is the investigation of choice for neuroendocrine tumors?
Stomatocyte receptor and
Anything?
PET CT,
Okay,
ma'am.
we'll come back to that later and I'll give you a chance to answer the second subdivision. The carcinoid syndrome is the right answer, and you want to do the serum markers and the PET CT. And
Yes.
some somatostatin receptor based investigation is the investigation of choice.
Yes.
Okay. So what is the serum marker for predicting prognosis and survival other than chromogranin A?
Synaptophysin.
Anything? The one that is given your standard textbooks. You want to add anything else?
I don't know exactly.
I'll pass the question to next candidate, that is Hasif. Seems name.
It's Dr. Hazik.
Hazik. Yeah, I'm sorry. Hazik.
Yes.
Now I got I've seen it in the screen. Hazik. Yeah, Hazik, you
Can
want to commit to something?
Can I answer the
Yeah,
specific?
yeah, you can answer it. What is the serum marker to predict prognosis and survival other than
No,
chromosomal?
ma'am. I'm asking about the previous, which
Yeah, okay,
specific.
yeah, you
It's
can
a
answer.
It's gallium 68 rotatate scan.
Very good. It is gadolinium rotatate.
Gadolinium rotatate. Yes, ma'am.
Yeah, okay. So what about this?
And then in other than chromogram, we use synaptophysin and vimentin.
Serum predictor other than chromogranin, synaptophysin. Okay. Anything else?
And vimentin also.
No, not vimentin. That has a good sensitivity to predict the prognosis and survival of the patients.
Okay. Maybe I'll come back on this.
Huh? Okay. I'll pass the question to the next candidate, that is Karthik. I'll give you a clue. It's given in Sabiston itself. This is to Karthik. Karthik, you're there?
Yeah.
Yeah. Other than chromogranin A.
Why HIA test?
What?
I don't know. Why hydroxy?
It has the sensitivity and specificity of chromogranin A. Okay. So I don't want other markers which doesn't have a good sensitivity and specificity for predicting the prognosis and survival. So I'll pass the question to Pritish.
Is it neurotensin B?
Yes, it is. Come again?
Neurotensin B.
Yeah, that is neurotensin. Okay, neurotensin is the right answer. We have one more marker, but since neurotensin is, it's also one of the important marker to predict prognosis and survival other than chromogranin is neurotensin. It is not synaptophysin. So I'll take that as a right answer, Pritesh. So you get the chance to answer the next question.
Ma'am, can you mention the scores for?
No, the question is not over yet. Don't get worried.
Got it.
Okay. FDA approved. So this is for you, Pritesh. FDA approved peptide receptor radioisotope used in imaging that has both diagnostic and therapeutic role. So this is the radioisotope scan imaging you can do, but it mostly has a therapeutic role. Since you said neurotensin, the right answer, you get a chance to win additional points by answering this question. What could be the FDA approved peptide receptor radioisotope used in the imaging that has both diagnostic and therapeutic role? Again, it is given in your standard books.
Radioisotope used is gallium 68 dotatate.
Dotatate has only therapeutic role. I'm really sorry, only diagnostic role. The one recent radioisotope being used has therapeutic role, not just diagnostic role. It's mostly used in therapeutics. It is given even in your NCCN guidelines, Sabiston and everywhere. Now they've started highlighting this radioisotope. Because it has therapeutic role, when the somatostatin receptor study is positive, then we can use this isotope as a therapeutic strategy. Can I pass the question? Since the time's up, I'll pass the question to Sneha.
No idea.
Yeah, that is fair. That is fair enough. So I'll pass the question again to the first candidate. That's okay, Sneha. We'll learn the answer. It will be very useful to crack one of your SS questions for sure. Don't get worried. So this is to
Dr. Akanksha.
Yeah, Akanksha, the first candidate. No idea?
Ma'am, is it
You can try
I'm
something.
guessing and I'm not
It's
sure.
okay, that's okay. Guessing is not at all wrong.
Is it a copper isotope? No.
Actually, 64 copper copper can
Copper.
be used in imaging technology, but that doesn't has therapeutic role. Okay. So I think the question hasn't passed on to Venu yet. Venu, you want to answer?
I think of lanreotide. Lanreotide is
No,
like
lanreotide is a medical therapy for a neuroendocrine tumor. Okay, it is not a radioisotope which will be given, which has a therapeutic role. Okay, it's a medical therapy.
yes.
The third candidate, the next one.
Lutetium.
Yes, what is it?
Lutetium.
Yes, very good. It is 177 lutetium. Okay, it's a radioisotope that is approved by FDA and it is given in your NCCN guidelines. Even in Sabiston, it is given with along with the trials. The radioisotope. It is
Netratrial.
lutetium. Yeah, it is NETAS trial. Very good.
Yes,
Appreciate
ma'am.
for coming up with the NETAS trial. I was hoping somebody would answer NETAS trial.
Yes,
NETAS trial has concluded lutetium can be used
Lutetium.
it has a therapeutic role. Good that you've told the point which will be useful for others. That's okay. Don't
Yeah.
feel bad. So this
Yes.
is said by okay, the third candidate. Okay. So you get 1 mark because it's a
Third,
past
I think
question.
not third, fourth candidate, Dr. Karthik answered.
Oh, Karthik answered it. I'm really sorry. Yeah. Thank you so
And
much.
the recent answer was answered by Dr. Venu.
No,
Two.
that's okay. That is an additional answer.
Yes, ma'am.
Okay. So now I'm giving Karthik another opportunity to grab one more point. To Karthik, this is scoring used during functional imaging for qualitative lesion assessment. This is definitely a tough question.
Ma'am, sorry to interrupt. I think we missed out Dr. Hasik. He's
But
third.
but this question was answered by Karthik, right?
Okay, got it. Sorry, ma'am. Sorry.
Yeah, only the candidate who answers the question will get a chance. Okay.
Understood.
So since
Yeah.
Karthik answered the question, he gets the chance to go through the maze and answer the next question.
Yeah, my
Score
bad, ma'am.
used during functional imaging for qualitative lesion assessment. This is like, I'll explain the question. We do so many somatostatin receptor based functional imagings for all this gadolinium, dotatate, everything we do for the neuroendocrine tumors, right? And depending on the radioisotope uptake to assess the to assess the lesion, there is an scoring used. Anybody who wants to?
Dowell.
What?
Dowell scale.
No, it's not that.
Renning scoring.
What?
Renning scoring. K is silent, I think. Renning scoring.
Yeah, it is. What is it? You're all.
Somatostatin.
No. Can you come up with the scoring again? Because since you
Renning
said
scoring. It is renning scoring.
yes, very good. That is the right answer. So let's move. So this is answered by Sneha, isn't it? Okay, so you get 1 point, Sneha, and let's go with the answers. I didn't really know that K is silent there, so I was confused. Okay, that's why I was thinking, what is it? So it's basically a small bowel neuroendocrine tumor with carcinoid syndrome. So after surgery and resection, we have to rule out metastasis with radionuclide imaging. So since the candidate has said radionuclide imaging and the carcinoid syndrome, I'm offering off of the points. It's a past question. And 177 lutetium is the radioisotope which is used in the treatment therapeutic role, not just diagnostic role. And the modified Krenning score, it's given your recent NCCN guidelines. Depending on the radioisotope uptake, this scoring can be used. So where did you read this, Sneha? I was very much impressed with the Krenning score answer. Krenning.
Ma'am, it was discussed by my consultant once, I remember.
Oh, wow. That's great, actually.
Recently only.
I think. Yeah, because lutetium 177 and all, and the NETAS trial, it's there in Sabiston, but Renning score, I read it only in NCCN. Yeah, okay. So you're all okay with the first question. We'll go to the second question. Before that, Karthik, we'll finalize the scores. Venu gets 2 points.
2, okay, ma'am.
Yeah, Karthik gets 1 point.
Okay.
Pritish gets 1.
Okay, ma'am.
Sneha gets 1.
Okay,
okay. So we'll go ahead with the second question.
Yes, ma'am.
The candidates, you're all ready. So it is to team B, that is Venu.
Yes, ma'am.
A patient who was a known case of neurofibromatosis and a Positive family history for the same, comes to the OPD with an history of painless swelling over his right shoulder from the past 3 months. The attending resident says it is mobile all around and looks like a lipoma. And I wanted to differ from the diagnosis. So this is the clinical video of the patient.
Yes, ma'am.
Yeah, you can watch the patient and the swelling. So the PGs have presented to me that this is a case of lipoma in a neurofibromatosis patient, and I wanted to differ from the diagnosis on spot. Not from the examination findings. I'll give you a clue also. So you guys also want to differ from the diagnosis. So this question goes to second team. Venu, what could be the probable diagnosis for the swelling in the patient? Upfront, right diagnosis will fetch you 4 points.
Can you repeat question? What I asked?
See, nothing. The neurofibromatosis patient comes to the OPD with the painless swelling over his right shoulder. Okay.
Yes, ma'am.
The attending resident has said it is mobile all around. It is firm in consistency, and it looks like a lipoma. Okay.
Yes, ma'am.
On seeing the patient and the swelling, even on seeing the patient without examining, I wanted to differ from the diagnosis, for which I have a solid reason, which I can justify. Do you also want to differ from the diagnosis and give some other diagnosis to this patient? I say it is not a lipoma.
Neurofibromatosis lesion, ma'am, I think.
Yeah, it is neurofibromatosis, of course.
Peripheral nerve means.
Yes.
Peripheral neuroma, something. Peripheral.
It should be a
peripheral neuroma.
I told you I want some accurate diagnosis. Peripheral?
Many.
Great.
Peripheral neurofibroma.
Is it a peripheral neurofibroma?
Yes.
I hope the time's being noted. It's only 60 seconds. Can you just let me know when the time's up?
Time up, ma'am.
Yeah. So I'll pass the question to third candidate, team C.
Yes, ma'am.
Yeah.
By the look of the swelling, there can be certain differentials in the background of neurofibromatosis.
No, I don't want a differential diagnosis. I want an upfront answer. I can justify my answer. And
can you show the video again?
Yeah, sure. No, I told you again. Think of the swelling in a neurofibromatosis patient. Don't go to the examination findings of the swelling. Okay. I just wanted you guys to see the patient, and the examination doesn't give you any clues for the diagnosis. Suppose if a neurofibromatosis patient is coming to you, your OPD with the swelling, what will be your first differential diagnosis in mind? What do you want to rule out?
Could be pyomyositis, something related to.
No, that's a wrong answer. I'll pass on the question to Karthik.
Nerve sheath tumor.
Yes. What is it? It's a
Malignant.
Yes.
Peripheral nerve sheath.
Yes, it's a malignant peripheral nerve sheath tumor. Why do you want to say it's malignant peripheral nerve sheath tumor? So you get 2 points for the correct answer, and justify your diagnosis, you'll get 1 more point. Why is it a
Usually we'll rule out the diagnosis.
What?
I don't know the exact answer. Usually we'll rule out that diagnosis.
Why do you want to rule out that in a neurofibromatosis patient? That's almost right. So I'll pass on this question to Pritish. So it's a malignant peripheral nerve sheath tumor in a neurofibromatosis patient.
Ma'am, it looks like a plexiform neurofibroma. It is one of the major criteria for diagnosing neurofibromatosis. So,
Come again, Pritish.
plexiform neurofibroma is
Actually, we have concluded the
generally-
diagnosis as malignant peripheral nerve sheath tumor for this patient. and we're just talking about justifying the diagnosis. Why does this particular patient can have malignant peripheral nerve sheath tumor?
Because in neurofibromatosis type 1,
Yes.
that is a known fact. It is prone for malignant peripheral nerve sheath
Yes.
tumors.
Yes, neurofibromatosis 1 mutation makes the patient
NF1
prone
mutation,
for,
yes.
yes, NF1 mutation makes the patients prone for malignant peripheral nerve
Nerve sheath tumors.
So what is a triton tumor? You get a chance to answer the third subdivision of the question. What's a triton tumor? It's completely related to malignant peripheral nerve sheath tumors. Since you guys are smartly preparing for SS exams, should be able to answer these things. What's a triton tumor? Can I pass on the question to Sneha?
Yes, ma'am.
Yes, Sneha. What's a triton tumor? You've heard it somewhere from your consultants.
Ma'am, I think it is a malignant peripheral nerve sheath tumor, but with a degradation in the rhabdomyolytic differentiation.
Wow, Sneha, I'm really impressed here. Triton tumor is a malignant peripheral nerve sheath tumor which has rhabdomyosarcomatous element. So, where did you read this? I'm just curious.
I'm reading it for SS only, I think.
So, this is given in Devita, be in your SS preparation thing. So
Thanks.
basically, I know this triton tumor because once we had a malignant peripheral nerve sheath tumor when I was doing my PG. So that time when I did, I got to know the point that it was quite impressive. I mean, it was a catchy name. So whenever malignant peripheral nerve sheath tumors have rhabdomyosarcomatous elements in it, it is called as triton tumor. It's as simple as that. Since the question is difficult, I have like allotted 4 points to it, and Sneha gets upfront 2 points. So Karthik, can you note the points? It is 2 points for our candidate Karthik. Pritesh
Okay, ma'am.
gets
Pritesh, how many, ma'am?
1 point.
Okay.
And Sneha gets 2 points.
Okay, ma'am.
Okay, yeah.
Oh.
So we'll move on to the third question after seeing the answers. This is a malignant peripheral nerve sheath tumor as there is NF1 gene mutation. That gene mutation was told by, I think Pritesh answered it. And lifetime risk of malignant peripheral nerve sheath tumors in patients with neurofibromatosis is 8 to 13%, might be useful for your exams. And I told you what is triton tumor is. So we'll move on to the third question. Third question to Hasik.
Yes, ma'am.
Yeah, 55-year-old female has come to the emergency department with an history of lower abdominal pain, fever, and vomiting from the past 4 days. She was initially treated by a nearby physician, and then the patient was referred here with a CT abdomen, and she was reported. I mean, she was referred as a case of appendicular mass. I've given the CT picture here, and we have done a diagnostic laparoscopy for the patient, and I have also added an intraoperative video. So after the video, your timer will start on the questions. Okay. So first look at the CT picture. I'll give you a few seconds. Okay. Then we'll go to the video. Sorry, the video is in the PPT itself. Yes. So this is the right iliac fossa. This is what we have found on entering the abdomen, and I wanted to differ from the diagnosis of appendicular mass. So this is how the pathology looked like. Okay. So we'll go to the question. Do you want to differ from the diagnosis based on
Can you play the later stages of the video?
Yeah.
Last part.
Yeah, sure. You can see the whole video again. It will be very useful for you guys because it was one of our interesting cases. So that is the finding on entering the abdomen. It's the right iliac fossa.
Is this from this white is?
Hasik, you cannot ask further questions from the question.
Yeah.
A clue to the answer then. So basically this happened to us. patient was referred with the CT. Your timer has started now. Referred with the patient was referred with the CT, and this was the intraoperative finding. Definitely based on the macroscopic appearance of a structure like that in the right iliac fossa, you can come up with some diagnosis. Even if it is closer, I would acknowledge the diagnosis.
This looks like an appendicular neoplasm, can be an appendicular carcinoid or
yes, this looks like I don't hear.
Appendicular neoplasm.
Appendicular neoplasm. Okay, you want to say it's a neoplasm?
Yes, ma'am.
Okay, looks like appendicular neoplasm.
Neoplasm.
Okay, that's all.
Can also be an appendicular carcinoid, but the macroscopic appearance looks like some kind of appendicular hydrated.
Appendicular?
Hydrated cyst, some cystic lesion.
Hydrated cyst. Okay. So since that's a grossly wrong answer, I'll pass on the question to Karthik. Karthik, you are ready? Be fast. The timer has ended actually. So I'll not give any time to think.
Appendicular mucosa.
Yes? Appendicular?
Mucosa.
Yes, that's a
Mucosa.
mucosal of the appendix. Why can't you boldly commit to an answer? It feels like as if I have to give some push. Okay, so it's obviously, you guys want to see the video? It's obviously an appendicular mucosal. And Hazik, you cannot say it's a neoplasm until it is proven in the HPE. So, okay. So whenever an appendix is macroscopically dilated like this, you can upfront rule out neuroendocrine tumors. Neuroendocrine tumors will be very small. It will be usually very difficult to localize any neuroendocrine tumor, be it appendix, small bowel or anything. So this is a classical case of appendicular mucosal, a very huge mucosal. We can call it as a giant mucosal of the appendix. And this was reported as an appendicular mass, but intraoperatively this was an appendicular mucosal. Macroscopic appearance, you should commit it only as a mucosal, not as a neoplasm, just based on the appearance. So since Karthik has answered it, I'll give him 2 points, and I'll also give him a chance to answer in the next part of the question. So what's the classification used for this kind of neoplasms of appendix, especially the epithelium neoplasms of appendix? They're commonly classified under one name, which also includes these kinds of mucinous tumors. It's a classification given in your Bailey. Again, might be very important for your SS exams also. What's the classification? If you don't know, you can pass on the question. That mucosal was an impressive diagnosis. So I'll pass on the question to Pritesh. So what's the classification used for overall epithelial neoplasms of appendix, which also includes mucinous neoplasms? Actually, you cannot even call this as mucinous neoplasm until it is proven in frozen or HPE. Based on the macroscopic appearance, try to learn. We should only call it as a mucosal of the appendix. That's all. Till the frozen section report or the final HPE report comes. So what's the classification used, Pritesh? I'll pass on the question to Sneha, hoping that she'll definitely answer.
I don't think, ma'am, it's named classification. It is WHO classification.
No, it's a named classification. Okay, WHO classification. No, it is named. It has a name.
No idea, ma'am. WHO.
Can I answer?
Only I know.
Okay, I'll give it. Okay.
Ma'am, can I?
No. After Sneha, it is Akanksha.
Pass on.
Yes. Venu?
Roni classification, ma'am.
What is it? Yes,
Roni
classification given in Sabiston, or you can even answer that as modified Delphi consensus classification. It's given in Bailey. So Venu gets 1 point. Okay. I think that's all with this. Venu gets a very nice chance to answer another question with 4 points. After surgery, we have done an appendicectomy for this patient. Okay. So after surgery, the postoperative HP has come as high-grade mucinous neoplasm of the appendix. Margins were negative. So what is the next step and how will you follow up this patient?
Saturated surgery with HIPEC. This since the high grade.
Okay, that's a wrong answer. So I'll pass the question to Hazik. You are getting another chance to answer this question, Hazik.
What surgery was done initially?
Initially, we just done an appendicectomy. Okay, to this same patient only. Okay, so this we did an appendicectomy because we wanted to see the HP, then manage the patient. You're getting the point, right? We didn't want anything unless the HP shows some neoplasm. Okay, so it was reported as high-grade mucinous neoplasm, margins negative. What is the next step and follow? At least tell me the next step since the question is tougher for everybody. Next step.
I mean, high-grade mucinous neoplasm, we generally do right hemicolectomy and followed by radiotherapy. And if it is having peritoneal.
I'm sorry, that's the wrong answer. I'm following only the, the protocols given in NCCN, so don't get worried. So I'll pass the question to Karthik.
Right hemicolectomy and tumor markers.
Okay. The first half of the question answer is not right. So Pritish, margin negative, high-grade neoplasm. Sneha?
Right hemicolectomy with hypec.
No.
Or cytoreductive surgery with hypec.
No, I'm passing the question to Sneha.
Ma'am, maybe first we will get the tumor markers.
Yes.
That is carcinoembryonic antigen and.
Yes. Okay. You want to do anything else to the patient other than tumor markers? You want to differ from others? You're not sure?
No, ma'am.
Okay. Okay, I'll pass the question to Akanksha, right? So this question started with Karthik, I think. So Akanksha is getting a chance to answer. What is the next step? When it is high-grade neoplasm, margins negative, how will you follow?
For metastasis and lymph node mets, we can do a PET CT to see if there are metastases elsewhere.
No, that's the wrong answer. I'll pass on the question to Venu.
I think I asked about the intraoperative findings due to spillage of the tumor. Spillage, something like.
No spillage was there.
Then I go chemotherapy or something.
Chemotherapy? Okay, that's a wrong answer. That's all right. Everybody got the chance to answer this subdivision. Hazik has got.
Ma'am, can I, ma'am?
No. After the wrong answer, I will give you another chance. Other candidates might get offended then. Yeah, Hazik.
Yes.
Hazik?
Yes, ma'am.
Yeah. What do you want to do to this patient if it were your patient? You're getting this report. How will you follow up the patient? You want to do anything?
Is it a radiological investigation you want to know in the next step?
I want to know what do you want to do this patient if it were your patient? Everybody said hypec cytoreductive surgery, right hemicolectomy and all. What do you want to do? Okay, time's up. So nobody is getting any points for this particular subdivision. If it's if the HP shows high-grade mucinous neoplasm, be it low-grade or high-grade, if the margins are negative, you will not do anything else to the patient. The appendicectomy suffice. Okay. Only when it is an invasive neoplasm, you will do right hemicolectomy. If there is gross peritoneal spillage with epithelial cells in it, then you will do all those hypec cytoreductive, the next plan of management, whatever that is. If it is an high-grade neoplasm with margin positivity, you will do a cecal cuff excision. Even then, there is no role for right hemicolectomy. Okay. And size will never determine further treatment management in mucinous tumors of appendix. The size is a factor only in carcinoids of appendix and not the mucinous neoplasms. Our patient had this huge mucinous neoplasm, but even then it was not invasive C or anything. It was a simple mucinous neoplasm. Okay. Be it low grade or high grade, you will just follow up the patient with colonoscopy, tumor marker, and abdominopelvic CT annually. Okay, you have to do a colonoscopy to all. At least if somebody had answered colonoscopy, I thought I'll give half of the points. Okay, but colonoscopy is mandatory for every mucinous tumor of appendix to rule out primary epithelial neoplasm from the colon. Okay, that is a standard protocol. Doing colonoscopy in every patient with mucinous neoplasm of appendix, and you will not do any further surgery. Okay, modified Delphi or Ronnie classification is given in Sabiston, so I'll take that as a right answer. You will just do an appendicectomy, wait for HPE and manage the patient. So Karthik, the points for this question is Venu gets 1 point and Dr. Karthik gets 2 points. Okay, that's all. Okay, so we'll move on to the next question. That is to Karthik, I think. It's a direct question to Karthik. I'm right, right? This is 4th question, right?
Yes, ma'am.
Yeah, okay. So Karthik, your question is, a 35-year-old male patient has come to the emergency department with palpitations, tremors and hemoptysis. On examination, he had a testicular mass and his beta HCG was 53,000 units per ml. So what is the diagnosis? I want an accurate diagnosis. This case can definitely be diagnosed based on this kind of history. He comes with a testicular mass. He has palpitations, tremors, hemoptysis, and his beta HCG was in the range of 10 to the power of 5 to 10 to the power of 6. We had this case who came to the emergency. And based on that, I have derived this clinical maze here.
Choriocarcinoma.
Choriocarcinoma, that's all. Choriocarcinoma. It has a name, choriocarcinoma. I mean, yes, it is choriocarcinoma syndrome. Okay, so I'll take that as a right answer, Karthik. It is choriocarcinoma syndrome. Why do you want to say this is choriocarcinoma?
Beta HCG high.
Yes, beta HCG is high. And why is the patient having palpitations, tremors, and hemoptysis? If you do not justify that, I'll give only half of the points.
Hyperthyroidism.
Yes, why is the hyperthyroidism there?
Beta HCG will mimic TSH.
Yes, beta HCG resembles TSH. So any patient who has gross elevation of beta HCG because of the extensive metastasis of choriocarcinoma. When there is a metastatic choriocarcinoma to the patient, choriocarcinoma patients can have extensive metastasis in the initial period of the time, which will result in the huge elevation of beta HCG of this, like 10 to the power of 5 to 6. And since the beta HCG resembles TSH, they'll have all the symptoms of hyperthyroidism. That's a very good answer, Karthik. So you'll get the chance to answer next question also answered, justifying the diagnosis. So what is the essential element in histology for the diagnosis in a choriocarcinoma? Actually, we'll call this as a choriocarcinoma syndrome. What is the essential element in histology? Cell in histology. I'm not asking about any advanced IHC markers or anything. Something in the histology should be there to diagnose this as a case of choriocarcinoma. If we happen to do an high inguinal orchidectomy and send the specimen for pathology. I'll pass the question. Okay, Karthik? Yes?
Syncytotrophoblast.
Okay. Is it No, syncytotrophoblast is a wrong answer. I'll pass on the question to Pritesh.
Biphasic nature.
No, this should be there to say this is choriocarcinoma, not syncytotrophoblast. You can even give a good guess. There is no negative marking.
Biphasic trophoblastic nature.
No, it's not biphasic that is not the thing I'm looking for. Okay, I'll pass on the question to Sneha.
Ma'am, it will have cytotrophoblast syncytial.
Yes, it is cytotrophoblast. Unless there is cytotrophoblast, it is not specific for, that is the only thing specific for choriocarcinoma. Syncytotrophoblast can be there in other subtypes also. So cytotrophoblast should be there to make a diagnosis of choriocarcinoma. So Sneha, you're getting a chance to answer the next question, that is manage this patient. So this patient is coming to your emergency department, you're attending this patient. So what is the first management you want to do for this patient? Not the investigation part, treatment.
We'll go for a radical orchidectomy.
Okay, that's not the right answer, Sneha. So I'll pass on the question to Akanksha. When such a patient arrives, what will be the first management you want to do, Akanksha?
Ma'am, first we'll control his symptoms, the palpitations, tremors.
Okay.
First, and then, since it's a metastatic lesion, first I think we should go for chemo and radio and then proceed with surgery once.
Actually, I will take chemo as right answer. Okay, I'll give 1 point to her. So chemo is the Sneha say it's chemo, it's not biopsy. Will not do a orchidectomy for this kind of patient. Since they are in a crisis, we'll first give chemo, especially will not give bleomycin. The patient can have lung metastasis also. So we'll give etoposide and platinum-based EP chemotherapy, control all the symptoms and the crisis. Then you will do one high inguinal orchidectomy in between the cycles. Okay. Okay, that is the clear-cut management for this patient. So choriocarcinoma syndrome, it's choriocarcinoma with the distal mets where the HCG resembles TSH. Cytotrophoblast essential for diagnosis, and emergency chemo is the treatment even before biopsy. You guys got the point? Okay. So we'll move on to the 5th question too. So at the end of this round, I'll tell the points. So it is 1 point for Akanksha, 6 points for Dr. Karthik, and 1 point for Dr. Sneha. Okay. Noted?
Yes, ma'am. Noted, ma'am.
Yeah, okay. I'll go ahead with the next question. That is the 5th question to Pritesh. An 18-year-old female has come with abdominal pain, vomiting, tiredness, weight loss from the past 3 months. She was pale and emaciated. Her abdomen had a mass, which is shown like how it is in the picture. CT images given here. After assessing operability, she was taken for exploratory laparotomy with this finding. I'll show you a video. There was a huge exophytic mass from the proximal jejunum. Postoperative HPE showed, spindle cells. IHC staining for c-KIT and PDGFRA was negative. Okay, so I'll show the video first. It's nothing but a huge exophytic mass. That is the transverse colon there. We operated this case around 1 month ago in a very young female patient. It was practically in the retroperitoneum, but after complete mobilization, we understood it is arising from the jejunum. That is the clue. Exophytic mass is the clue. Okay. Yes, this was the CT picture, and that was the location of this mass. So, Pritesh, do you want to?
Ma'am, CT picture.
Yeah, this is the CT. And heterogeneous mass lesion with the vascularity, highly vascular mass lesion. Exophytic mass arising from the jejunum. Just keep listening to me. I'll be actually giving all sort of clues possible for your level, PG level. It's an exophytic mass from the jejunum.
Ma'am, IHC staining for c-KIT and PGDFRA was?
Yeah, it was negative. This was a young female. IHC staining negative, but it was an exophytic mass like this.
Leiomyoma?
Leiomyoma, you want to specifically, no, I cannot take leiomyoma as an answer.
Spindle cells with negative IHC tends to leiomyoma. Positive would go to GIST.
Okay, yeah. It is a GIST arising. What? What did you say?
Gastrointestinal stromal tumor.
Yes, it's a gastrointestinal stromal tumor arising from the jejunum. So that's the right answer. Is getting upfront 2 points. So you will, what are the predictors for prognostication in GIST, which will predict the both prognosis and the recurrence? Predictors for prognostication and recurrence.
Synaptophysin, chromogranin A, synaptophysin, neurotensin B.
Why do you want to go to all of a sudden to some neuroendocrine tumor from GIST.
Predictors of prognostication, ma'am, if we go
Yes.
for management of this patient, like if we resect the tumor,
Yeah, after that,
clear
post-operative
margins,
yes.
clear negative margins would be under good prognosis.
Okay, that's a gross wrong answer. I'll tell you why. So I'll come back to you later, Pritesh. Sneha, any predictors for prognostication and recurrence in GIST post-operatively? HPE will show all that.
Tumor size and
Yes,
mitotic
very good.
index
Tumor size?
and mitotic index.
Very good. I'll take that as a right answer and I'll give 1.5 points to Sneha upfront. You want to add one more point?
Excuse me, ma'am.
Yes.
Ma'am, would you have mentioned post-operative prognostic factors? I would have.
I said. I told you clearly. I told you. You didn't listen to me. Ask other candidates. I told so many types post-op HP. Then you came up with clear margins. Pritesh, clear margins is not doesn't signify prognosis in GIST. Go back and read. Even if the margin is positive, it will not affect the prognosis in a patient with visceral GIST. Okay.
Sure.
So margin positivity is a wrong answer. That's a grossly wrong answer because it's very clearly given even in your NCCN guidelines. Even if the margin is positive, it will not affect the prognosis. But whereas the tumor size and the mitotic index will affect the prognosis. Okay. So there is a criteria. There is a named criteria. I'll come back to that later. So the predictor for prognosis, I said post-op HPE. Then only you said margins. Okay. So let's not argue here. So you want to add one more point for prognosis and recurrence, Neha? Other than
site.
Yeah, site. What did you say? Site. That
site
is,
of the tumor.
Yeah, site. Site of the tumor will definitely determine the prognosis. For example, gastric GISTs have got better prognosis than other type. Okay. So it's only the site, size, and mitotic index. Only 3 things. It's clearly given in your standard textbooks. Okay, for recurrence and to predict the prognosis and recurrence. So Sneha, what could be the IHC staining? Staining or probable mutation in a young patient having GIST if it is negative for both c-KIT and PDGRA4. I mean, platelet growth factor receptor alpha. The 4 is the points.
Mom, it is a wild type mutation, SDH deficiency.
Very good, very good. Come up with that. Yes, say that again. That's the right answer.
SDH deficient wild type.
Yes, it is HTH deficient GIST. Okay. A very big applause for you for coming up with that. So usually in a young female, c-KIT and PDG RA will be negative and it will be only positive for STHB mutation, which will result in loss of HTH and staining for STH will not be there in IHC. Okay. So what will you rule out in such a clinical scenario? Do you want to come up with any familial thing? Because
I'm Carney's tried.
Yeah. So do you want to rule out anything else in this patient?
Pulmonary chondromas and paraganglioma.
Very good, very good, very good. I'm giving you 2.5 points, Neha. So that's a very good answer. So it's a classical case of GIST arising from the jejunum. Fletcher's criteria. Okay, that is Fletcher's criteria, which says tumor size, mitotic index. It's given in your NCC and also only these things are prognostic indicators and indicators for recurrence and margin positivity will not affect the GIST. Okay, have that in your mind. It is STHB mutation and you have to rule out paragangliomas in a young female like this. You have to think of Carney-Stratakis syndrome. Carney-Stratakis syndrome just with paragangliomas. Carney's triad includes pulmonary chondromas. You can learn that additional point here. So we'll move on to, I'll tell the points of this round. So this question was to Pritesh and he got 2 points. And Sneha has totally got 4 points. 2 points to Pritesh and 4 points to Sneha. Is that okay? Got it? Noted. Yeah, yeah. So we'll going to the last question of the round. Sneha, this is for you. So 33-year-old male has come to the surgery OPD with the mass in his left side of the neck. Examination showed enlarged lymph nodes in the left posterior triangle. The lymph nodes were mobile and they were not mated. Before doing an FNAC, a CECT neck was taken, of course, after taking an USG. So images are shown here. There is an obvious finding in the CT, on seeing which my residents have actually diagnosed the case. So first I'll show you the CT. Have a close look at the CT. I've doodled it for your convenience. Okay, so then I'll show you the clinical video. So this is his left-sided, this is the left-sided mass lesion of this patient. Correlate this with the CT picture. There is also a very good clue in the video. So this 34-year-old male coming with a mass in the mobile mass in the neck, and CT is like this. Your time starts now, Sneha. Diagnosis for this patient, and can you justify your diagnosis if you're diagnosing?
Is it a carotid? I'm not sure.
Okay, I'll pass on the question then. So the
Not
image.
pass.
Okay, okay. So I'm passing the question to team A, Akanksha. Can you see anything in the CT and make a diagnosis for this patient? And the video was also shown.
Ma'am, is it
Yes.
liposarcoma?
Why do you say this is liposarcoma? Da?
Ma'am, because the mass is mobile and it has got slip sign. That's why I thought maybe. And plus, it's not innervating anything. It's out of the muscle. It's not.
Okay, okay. No, that's a wrong answer. I'll pass on the question to Venu.
Ma'am, I think it is secondary deposits in the posterior triangle.
Yes.
Due to some necrosis is present in the
Secondaries in the posterior triangle accepted. And do you see any feature in the node that gives any on the primary?
That is not a metal. That's why TB is ruled out.
Yeah.
That's why most common posterior tumors are secondary deposits.
Secondary deposits from where?
Nasopharyngeal carcinoma.
No, that's a wrong answer, because you can see something in the nodal mass and you're missing out the CT films. Giving you 10 more seconds to look at the CT film again. I have doodled it.
Calcifications are present.
Yes. So?
Yes.
I'm sorry. Okay, I'll pass the question to Hasik.
Yes, ma'am. These are cystic, nodal mets. The primary you are asking.
Yes.
It could be base of the tongue or a palatine tonsil or an oropharyngeal carcinoma.
No. Actually, Venu was given a very good clue. Karthik? Karthik? Calcifications in the node. He has came up with it.
No.
You want to pick up on that clue? I want to proceed with the question. I want somebody to tell the answer.
Hodgkin's lymphoma.
No. So Pritesh, now you're getting a chance to score your points. Pritesh, calcifications in the node, and this is the patient video once more. Okay, Sneha.
Ma'am, I'll take a guess.
Thyroid.
Is it a
What was your question only?
It is a tubercular lymphadenitis.
I
No.
clearly said the notes were not mated. Okay. So no one has scored anything in this question. Now let's just discuss the question. I'm not giving another chance to anybody.
After the video, can I answer? Maybe.
Yeah, but you can just attempt to answer. I'll not give points. Yes, Hazik.
After the video, I mean, was evident can be a papillary carcinoma thyroid.
Very
Shows
good. It's a
microcalcification.
papillary carcinoma thyroid. The patient is swallowing so many times. I'm telling you, there are clues in the video, clues in the video. Why do you want to go to so many things when the commonest is common? I mean, usually we'll encounter only like these kinds of cases, no? It's not a tuberculous lymphadenitis. See, the patient is swallowing twice. I'm asking the patient to swallow again and again because I'm thinking it is PAPCA. He came with a CT picture which showed.
Some of what is.
Yeah, some of my bodies. And every one of you have missed. Can you please go back to the first doodle area? That is that is thyroid gland with calcification. The second one is the node. See trachea, either side of the trachea. Can you see calcifications in the thyroid gland?
Yes, ma'am.
Why do you get calcifications in the thyroid gland with secondaries? It's only in papillary CA. It is amoma bodies. Actually, once what happened is one patient came with one MNG thyroid. She had calcifications, but the FNAC was benign. But in the gut feeling, we did total thyroidectomy with central neck node dissection that came as PAP-CA. Intralesional or intranodal calcifications, very significant for diagnosing papillary CA. These are clinical things you have to apply from what you read in the books. You're all concentrating on so many facts for exams, for cracking all the MCQs, so much of theory. But everything is a real life scenario which we have faced, and all of them were our cases, all the clinical scenarios. And I wanted to make you a point on, like, I wanted to make you guys like learn on how to apply all those things, what you read in books to the patients. Then only you'll become good clinicians and better surgeons. Okay. It's not just about cracking some MCQs. Okay. So we'll go ahead with the questions just to learn. Diagnosis and justification we have told. So it's actually a lateral aberrant thyroid. Primary must be a papillary CA because there is intranodal calcification and also intrathyroidal calcification is there. This was actually a very easy question. So suppose if the FNAC is coming as Bethesda 3 or 4, how do you guys want to like evaluate?
Total thyroidectomy with
Bethesda 3 or 4?
Bethesda molecular testing.
Yes, it's molecular testing. What's the molecular testing you want to do?
It's glycopric.
Anybody else? It's given in Sabiston. Yes, Thyrosec V2 and V3 has come up. It is given in Sabiston. That's an MCQ point for you. Treatment plan. Whenever patient has lateral neck nodes, you have to do a total thyroidectomy, lateral neck node dissection, and you should do a prophylactic central neck node dissection. One indication to do prophylactic central neck node dissection in patient with differentiated thyroid carcinomas. One is lateral metastasis and one more is T3 and above. You'll do a prophylactic central neck node dissection even when the nodes are not enlarged. And central neck nodes will be evaluated only intraoperatively. Your ultrasound CT cannot pick up the central nodes. Okay. So we have finished this round. And
Ma'am,
yes.
Thyroid in papillary mets mostly to the anterior triangle.
Papillary thyroid is the only thing that causes skip metastasis to station level 5. Okay. So lateral aberrant thyroid only in PAP-CA. Follicular CA will cause bony mets and not lymph nodal mets. That is the reason why in follicular CA, prophylactic central neck node dissection is not indicated. In no cases of follicular CA, we'll usually do an MRND. PAP-CA, so far I've seen around, like I myself operated around 3 to 4 cases in a year with lateral metastasis. Okay. But follicular CA will not come with any lateral neck nodes. Lymph nodal metastasis common only in PAP-CA. Okay, follicular only bony metastasis. And also PAP-CA has this peculiar tendency to produce skip metastasis. That is called a skip metastasis to the posterior triangle. That is the reason why we have a term called as lateral
aberrant thyroid.
This lateral aberrant thyroid term applies only to you take an FNAC from the node and you give it to the pathologist, they'll upfront report it as PAP-CA. Okay, all the papillary deposits will be there in the posterior triangle. Okay, so that is the answer. So at the end of this round, my scores must be right. I'll cross check with the DocTutorials team. Akanksha has scored 1 point. Venu has scored 3 points. Hazik hasn't scored anything yet in this round. Karthik has. Yes. Okay, Karthik has scored 5 plus, very good. 11 points. Karthik has scored 11 points. Pritesh has scored 4 points. And Sneha has scored 4 plus 4, 8 points. Okay.
Ma'am, this last round, no one has scored anything, ma'am.
Yeah, no one has scored anything. When you didn't diagnose, how will you get a chance to answer other questions? You wasted the question. What will I do? I thought at least one of you will come up with papillary CA, and actually I had a dilemma in taking this question. I thought this will be the easy question. That's okay. Any lateral neck nodal metastasis, and the patient is swallowing so many times in the video. That was a clue, and CT calcification was the first clue. CT with an intranodal and intrathyroidal calcification. You guys should be able to interpret the obvious findings in the image. There was no necrosis and all. Okay, and I also said it is not mated lymph node, so it's a secondary deposit. So many clues were there. Yeah. So are the scores okay?
Yes, ma'am. Dr. Akanksha 1, Dr.
Yes.
Venu 3,
Yeah.
Dr. Hasik unfortunately didn't score, Dr. Karthik 11, Dr. Pritesh 4, Dr. Sneha.
8.
Yes, ma'am.
8 points. Yeah. So now I'll hand. The next round will be conducted by another faculty.
Dr. Vikashini, ma'am.
Yeah, Vikashini, ma'am.
Dr. Vikashini, ma'am, you're there?
Yeah. So hi, good evening. So coming on to the second round, I'm Dr. Vikashini, gonna conduct the second and third rounds altogether. Yeah, we'll just directly jump into the rounds, rules of the rounds. So this is, I think this will be the easiest round, but please stick to the rules. And yeah, I'll read out the rules for you. Now here, each candidate gets one set of clues. There will be 3 set of clues, like 3 clues for each question, and each candidate will get one set of clues. And a candidate must answer within 50 seconds after first clue and 15 seconds after the subsequent clues. Okay, and early answer gets higher score. Answer after the first clue will be 15 points. After second clue, 10 points, and answer after the third clue will be the 5 points. And only one attempt is allowed per clue. So, like, you cannot revise your answers. You can think an answer within the stipulated time. Once you have given a single answer, if it is right, you will be given the score. If it is wrong, I'll just move on. Okay. And again, only a complete answer will be given the corresponding points. No points are awarded for incorrect or incomplete answers. Please don't claim half marks and something like that. And the question, if it is a wrong answer for the first clue, the question continues to the next clue. And even after all the clues are revealed, and if it is unanswered, the question passes to the next candidate. And the first correct complete answer gets the 5 points. So the past question gets only 5 points because all the clues would have been revealed by the time. And if the past candidate also answers incorrectly, and that candidate is logged out for that question, and this question can all the questions can be passed only once. It's not like the previous round, it goes by next. The question can be passed only once, and that is to the next candidate. And the candidate must justify the link between each clue and the final answer to be eligible for scoring. So are you guys clear with the rules? If there is any doubt, please clarify it right now, because next we'll directly jump into the clues.
Ma'am, one question for one candidate.
Yeah, there's only one question for one candidate.
All 3 clues are revealed by that person only. Can ask.
If if that candidate gives a wrong answer, only then the candidate moves, question moves to the next candidate.
Second candidate can get clues again and ask.
Yeah, by the time the question passes to the next candidate, all the 3 clues will be already revealed. So you answer after the first clue is wrong, for the same candidate only, the second clue will be revealed. And for
First,
the
you,
same candidate only, third clue also will be revealed. So at the end of the third clue, if the candidate is not able to answer, and then only the question passes to the second candidate, and that's all. It's passed only to the second candidate.
yes.
Any other doubts? Okay. So the first question is for it. Say it will be a fun round, easiest round. So just relax and answer. Now the first question is to Dr. Akansha. Akansha, you're ready?
Yes.
Yeah. And your time starts now. 50 seconds.
And can you?
Yeah, this is first clue. So I have numbered the images. So first think of one. What is this?
Living room.
What is this first image?
So living room.
Living room. Other name for that? And
Hearing.
other name? Okay, then third image. What do you do with this? You
Measure.
measure
Wait.
what?
Wait.
Okay, it's actually I thought this is the easiest one.
Time up, ma'am.
Okay, the time is up. Okay, then we'll proceed with the second clue.
Like Poland syndrome.
It's not syndrome. See, first clue, second clue. What is here?
Mastectomy scar.
Yeah. What is the answer? Give the answer.
Halsted's
Yes.
mastectomy.
Yeah, very good. It's Halsted mastectomy. So coming back to this one, this is Hall.
Hall.
This is Sted.
now I know.
Yeah, that's why I told you it will be a fun-filled round. So just relax. And this is mass. This is technology, and this is tummy. So
I got so confused. Yeah.
But not all rounds are like that, but still. Anyway, you're getting a score of 10. Akansha gets a score of 10. Anyway, good try. Just like that's why I told you, just chill out, guys. Yeah. This is the third clue, and it's nothing but a removal of breast tissue between pectoralis and skin, along with nipple areola complex, both muscles, major and minor pectoralis, and axillary level 1, 2, 3. All this is simple. Oh, sorry. And now coming to Dr. Venu.
Yes, ma'am. Yes,
Are you ready?
yes, ma'am.
Okay. So time starts now. What is image 1?
Laptop.
What is around that?
Internet.
Okay. Look at image 2.
BP, cough and heartbeat.
Oh, what is that? What is and what is it? Image 3?
Vomiting.
What
blood worm,
yeah.
bloody vomiting.
Yeah, 3 is right. What is 2?
Headache, palpitations.
See the sphygma. What does it show?
Sphygma.
That's what is the BP there?
Time up, ma'am.
Time up. So going on to the second clue. So this gets only 15 seconds.
Spleen.
Spleen? Spleen is?
Laceration.
Yeah, a spleen is lacerated. What is it? Look at the size.
Grossly enlarged spleen.
So what is that? So
Massive spleen. Massive spleen.
Splenomegaly with
Time
hemoptysis.
up, ma'am.
Okay, again. Next clue.
Oh. This ma'am. Tube ma'am. Less. Modified Malcut. Some Malcut. Modified.
I like time is up. I need
Time
you.
up.
Yeah. I need you to give up the answer right away. So, coming back to the clues, this is portal hypertension. See, and hemoptysis.
Yes,
It won't be passed.
Oh, I'm sorry. Yeah, the question gets passed to Dr. Hazik.
Yes, ma'am, it's a varicose bleed, esophageal varices. Here we can see in the endoscope as
Hey,
well.
at least with this second clue, second image, Dr. Venu, you're getting
Yes,
it right.
I'm ma'am. What you ask diagnosis or scenario? What you ask?
But you didn't come up with any of those things, right?
Splenomegaly, varices.
You need to relate, correlate the links. There should
What
be a link.
and what you ask? Exact diagnosis or portal hypertension is a
If
broad
it is-
term now.
Yeah, see, if you are saying it's splenomegaly,
Varices.
just a splenomegaly is not an answer. You have other clues also, right? You have 1, 2, 3. You need to correlate. So,
Mm.
answer should be common to all these images. An
Yes, ma'am.
answer common to all these images should be given.
Yes, ma'am.
Got it?
Yes, ma'am. Yes.
Okay, and so you're not getting any score here. And
Yes,
Dr. Hazik, can you explain?
This
Dr.
is
Hazik?
basically a case of upper GI bleed because of esophageal varices, and this is the, one of the methods
Minnesota.
we use.
Okay, what is this? What is this?
Minnesota too.
Minnesota tube.
Wait, Dr. Hazik, let him.
Yes, ma'am.
Yeah. What is this?
It is a Minnesota tube because it is having two. Initially we use
What's the
sense-taken.
name of this tube? Name of this tube.
Sense-taken Blackmore. You want to?
I need the complete answer. Even one
Complete answer?
word. Yeah, even one word missed also you'll not, because you need to link between the clues and the final answer. What is the name of? Because all the 3 clues have been revealed by now. So I'll take it as you answered only after revealing the 3rd clue. So that must be a clear link between the 3rd clue and the answer. So you made it the answer with the esophageal varices. That's right. But what is the link between this image and the answer?
This is initially used as a, to control the upper GI bleed. It can be sense-taken Blackmore tube which is used. But this is Minnesota tube because it is having 2, outpouchings only. It is not having four ways. You want to know the exact name of this tube?
Yeah, you're all totally right. You just missed out only one word.
One word. Of what one word I miss?
That you should only come up. What one word? Okay, then I'll go up, show you the answer. This is esophageal varices. That's the answer anyway. Oh, sorry. Yeah.
I mentioned this.
You mentioned it?
Yes, ma'am.
Yeah. Okay, then. You mentioned it means your Dr. Hazik is getting 5 points in this round.
Okay, ma'am.
Okay. Shall we move on to third clues? And this is to Dr. Hazik, I guess, if I'm right.
Yes, ma'am. Yes, ma'am.
Okay. You have a lot of clues in this, and the time is up.
Einstein, jail, virus, car.
What is the 6th clue?
6.
6 is?
It's a no kind of signal.
No. What is the 7?
Love affection.
What? Short form.
Love, affection, care.
What is this? First image, Einstein, IN to P. What is this? In Einstein, IN is converted to, change IN to P. What is that? Time is up.
IN.
Time is up.
Yeah.
Okay, I'll
Second clue.
move on to the second clue. Time starts now.
Hemoptysis and humming, ringing.
It's not hemoptysis.
Blood from the nostrils.
Bleeding from nose.
Bleeding from the nose.
What is bleeding from nose? It's not hemoptysis, it's epistaxis.
Sorry, epistaxis. Yeah, epistaxis.
Okay, final clue. Time starts.
It's a nasopharyngeal carcinoma.
It's a nasopharyngeal carcinoma, but you'll get the point only if you link it.
Link it with what, ma'am?
Link it with these clues.
Nasopharyngeal carcinoma, which is having the propensity to bleed, and that is why the patient is having epistaxis.
What is the second image?
Patient is also having, buzzing, roaring, ringing, humming, and crackling sounds. Some kind of, it is compressing the.
What is the symptom called as? What is the symptom called?
Meniere syndrome.
Symptom.
Symptom.
Yeah. Second image, symptom. Okay, time is already up.
Sensory neural hearing loss.
No, I'll you'll be given half points, and the question passes to Dr. Karthik. Can you link the clues? Just the answer is already given by Hasik. Dr. Karthik.
Epstein-Barr virus.
Very good, very good. So this is Epstein-Barr virus carcinoma. Got it? It's like Epstein-Barr virus. Okay, the second clue. What is this image? Symptom?
Tinnitus.
Very good, very good. It's tinnitus.
Tinnitus.
So
Okay.
epistaxis, tinnitus. Very good, very just a, and this
Right.
is a straight away clue. Okay, so in this round, Dr. Hasik gets 5 points and Dr. Karthik gets 5 points. So this is an nasopharyngeal carcinoma with most common association between Epstein-Barr virus, arises from fossa of Rosenmuller, and presents with obstruction, epistaxis, and tinnitus. Okay, now moving on to Dr. Karthik. Fourth question. Karthik, are you ready?
Yes, ma'am.
Yeah. This is the first question. Your time is up. It's very easy.
Next clue.
Very easy. What is the first image?
Smile.
Smile. Okay, 2. Second.
15 seconds.
Third image. What is it for? What does the third image show?
Fist, ma'am.
Yeah. 5. 4 is pointing you.
Pointing.
Okay, and moving on to the second. If you are not able to find out the first one, the second clue. Time is up. Like time starts now. I think Dr. Venu has come up with an answer.
No, ma'am. It's something.
Okay, time up.
Time up.
Dr. Karthik, you want to answer now or we'll move on to the third clue? Karthik? Okay, third clue.
Now we can move on.
Yeah. What is this? What is this? What is this?
Intracutaneous system.
Very good. It's a like
Time up, ma'am.
yeah, time up, and he gave us the answer. Like, can you link it? This image is okay. Can you link? What is friends? In like first of all, I'll explain this because anyway, this is E. This is C. EC. Fistula. Okay. Fistula. Now I want you to link, come up with the link between the EC fistula and friends. Only if you answer this, you'll get full points. What is friends in EC fistula? Okay, the time is already up. The question passes to Pritesh. Dr. Pritesh?
Yes, ma'am.
What is friends in
Ma'am, friends is acronym for high output fistula.
Very good. It's a acronym. And can you expand this acronym? What is F? The cause of fistula.
Foreign body radiation.
Very good. Very good.
high output and
I for?
stool.
Like you already got the point. The link is, it's the acronym for the cause of
Acronym for causes of high output. So EC
yeah.
fistula, non-healing of EC fistula.
Yeah. I stands for? Okay, then at the end of this round, Dr. Karthik gets 5 and Pritesh gets 5 points. I'll just show you the expansion for friends. So, foreign body, radiation enteritis, IBD or infection, that is irritable bowel disease, and E is epithelialization of the tract, which also prevents the closure of the tract, fistula, and N stands for neoplasm, and D for distal obstruction. So, are you done with this question? Like, you're able to get what, right? And now the direct question is for Dr. Pritesh, I guess.
Yes,
Yes.
Yeah. Pritesh, I'm going to show the first set of clues. And the time is up. What is first image?
Hair.
Hair. And second is?
Hair nest.
Nest in?
Hair nest in
What
Latin.
is it? Latin. Yeah, what is Latin for hair and nest? Okay, then come to the image 4. What is this?
Sign.
Sign. This is?
America. USA.
So sign? Sign?
Sinosa.
Sinus. Sinus. So what
Sinus.
sinus?
Hair
4
and
and
nest
5 is
sinus.
sinus. Sinus. What sinus?
Time up, ma'am.
Time up. Coming to the second clue, you'll get it right now.
Pilonidal sinus.
Very good.
Limber flap. Pilonidal sinus.
Yes. Very good. So this is
Hair and nest, the link is for the etiology, ingrowing of the hair. Which...
Very good, very good. So you're getting full, like not full, you're getting 10 points for this. So Pritesh scores 10 points. Yes. Pilonidal. So pilus and nidus in Latin. Treatment is Limburg flap. Now, Dr. Sneha.
Yes, ma'am.
Are you ready?
Yes, ma'am.
Yeah. And time.
Triangle, some triangle.
Triangle. Yeah. And who's this? You can also give a guess because one guess is allowed. Like it's triangle or it can be a triad also. So time up. We'll go to the next clue. Yeah. What is this first one?
It is for obstructive jaundice.
Yeah. It's
Courvoisier's law. Courvoisier's time.
It's see, already you have given answer. It's see what is first image? It's
it is melena, and then icterus, then abdominal pain. It is indicating obstructive jaundice.
See, but obstructive jaundice, it's not a triad, right? It's not a triangle. So yeah, like I'll move on to the next clue because he gave a wrong answer. And what is this? What is this needle?
LP.
LP needle. Any other named name of this needle? It's a spinal needle. Spinal needle is also called as. Time is up.
Yes, ma'am. Time up.
Okay. Dr. Akansha, you get a chance. Akansha.
Ma'am, is it just guessing?
Yeah.
Is it Charcot's triad? No.
Charcot. No, it's not Charcot's. Okay, no, anyway.
Ma'am, can I answer?
Can I?
Anyone can answer now, but no score.
Which
Quincke's triad for hemophilia.
Very good. Who gave that answer?
I did not.
Pritesh, Dr. Pritesh.
Mhm.
Yeah, that's the right answer. It's Quincke's triad for hemophilia. So it's a triad is composed of melena, jaundice, and colicky pain. Okay, now at the end of this round, we'll just wind up with the scores. Dr. Akansha has scored 10. Karthik, just check with the scores.
Yeah.
Yeah,
This round, Dr. Akanksha
yeah, this
scored
round. Yeah,
Dr. Venu 0, Dr. Hazik
Harshik,
10,
10.
Dr. Karthik 10, Dr. Pritesh 15, Dr. Sneha nothing. And overall scores after round 2, Dr. Akanksha with 11, Dr. Venu with 3, Dr. Hazik with 10, Dr. Pritesh with Dr. Karthik with 1 second, ma'am. Yeah.
21.
Yes, ma'am. Dr. Karthik with 21, Dr. Pritesh with 19, and Dr. Sneha with
8.
8.
Okay. Okay, now moving on to the challenge round. So this challenge round rules are quite tricky. So I just want you people to listen to it carefully. If any doubt, just clarify it. So see, in challenge round, there will be 6 questions. Each candidate will get one opportunity to challenge. Okay. So one candidate challenges another candidate to answer a question before the question appears. So before the question appears, say for example, Akansha wants to challenge on some other candidate. Say for example, Karthik. It's an example. Like that, one candidate challenges another candidate to answer a question before the question appears. And each question carries 10 points. Only a correct, complete answer will be awarded full 10 points. Partially correct or unanswered, all this will be treated as incorrect. The challenged candidate answers first. So if Akansha is challenging on Karthik, so Karthik has to answer it first. And Karthik gets 50 seconds to answer that. So challenged candidate will have 50 seconds to answer. If unanswered or if it is incorrect, the challenger will get 15 seconds to answer. So Akansha again gets 15 seconds to answer that. Got it? So far clear?
Yeah. Yes, ma'am.
Yeah. And time starts immediately after the question ends. And if the challenged candidate answers correctly, so if Karthik has answered correctly, 10 points will be deducted from the challenger. That is, it's minus 10 for Akansha and plus 10 for Karthik. And vice versa happens. If the challenged candidate answers incorrectly, the challenger gets the opportunity to answer. So if Karthik has answered wrong, Akansha gets a chance. And if the challenger answers correctly, it's minus 10 for the challenged candidate. That is minus 10 for Karthik and plus 10 for Akansha. Got it? So far clear? And if
Okay.
both candidates fail to answer, minus 5 for both. Akansha also minus 5, Dr. Karthik also minus 5. Okay? I hope the rules are clear.
Hello.
And one more. Yeah. And
Ma'am,
last,
everybody. Okay.
yes, yeah. Each candidate can be challenged only once. So if Akansha has challenged Karthik, nobody else can challenge Karthik. Otherwise, Karthik keeps losing points, right?
Yes,
So
ma'am.
only Akansha has challenged Karthik, then maybe Venu can challenge some other candidate like Sneha or Pritesh. So only each candidate can be challenged only once. So are you guys clear with the rules?
Ma'am, is there any elimination round, something like?
No. There's no elimination. It's not elimination, though.
Ma'am, so it can happen that the one person who challenged some other person can get challenged. So everybody has to get challenged once.
Yeah, everybody will get chance. See,
All 6 will
Akansha
be
can,
get challenged.
all 6 will be, yeah, all 6 will be challenged. Akansha, say for example, Akansha can challenge Karthik, Venu can challenge Pritesh, Hazik on Sneha, and Sneha on Akansha, and something. Everybody gets challenged because there are 6 questions, right?
Okay.
Got it?
Yes, ma'am.
Here were the rules.
Ma'am, attempt negative marking for attempt.
Attempt negative? No,
Just
negative marking.
incorrect.
But you
But
just
wrong answer will be negative, right, ma'am?
no. There is no. Yeah. See, only one attempt can be made. Think and answer.
Only one attempt. That's
Only
what
one attempt. Yeah. Only one attempt. You cannot revise your answers. think an answer. If it is wrong, then it will get passed to the challenger. Okay.
After getting passed to the challenger, no points
other
and no
pass.
passing. Everyone gets -5.
Yeah, not everyone. The two
Both
involved
of them. Yeah.
candidates. Yeah. Any other doubts? See, rules clear, right?
Yes, ma'am.
Okay, so Akansha, you're the guinea pig here.
Before the question arises, does the challenger have any information on the question so that
No,
the topic,
nothing.
so that it can choose the challenge? Okay.
No, nothing like that. So, Dr. Akansha.
Ma'am, can we start reverse order?
Yeah.
Every time Akansha is starting first.
Yeah.
So
Okay. Now
this time we will start.
This time we'll start the reverse order. So, Dr. Sneha.
Yes, ma'am.
So this time you're the guinea pig. Are you clear with the rules?
Yes, ma'am.
Okay then. So whom do you want to challenge?
I'll challenge Dr. Venu.
Dr. Venu. He is already on. Okay now. Karthik, just have a note. Dr. Sneha is challenging Dr. Venu.
Noted.
Okay. So Venu, you have to answer this question.
Yes, ma'am.
Now here's your question. So this is the image showing the metabolic effects that happening in a burns wound. Now the question is, what is the physiological basis for hypermetabolism following severe burns? That is it. It's already clearly shown here. This is the basis for the hypermetabolism. And what causes this? See, explain the mechanism behind increase in levels of all the stress hormones. Basically, you need to explain this box.
No,
the time starts.
rise of enzymes like ECG, like epinephrine, cortisol, and
That's
glucose.
already given here.
Yes.
Explain the mechanism.
Rise in the cortisol protein breakdown like glycogenolysis.
No, what
formation.
causes catecholamine increase?
Stress.
That's a vague answer. Mechanism, which pathway or which axis, something like that. And what causes increase in glucagon?
Rise in the epinephrine.
Cortisol increase.
Cortisol insulin leads to glycogenolysis. Hypermetabolism leads to decrease low.
Time up, ma'am.
Time up. Time is up. Now, Dr. Sneha.
Ma'am, this is a case of HPA axis stimulation in burn cases.
Very good. So
it leads to sympathetic overdrive, and which ultimately causes gluconeogenesis and increase in oxygen consumption and cardiac output.
Glucagon.
And yes, it will cause gluconeogenesis, so it will lead to increase in glucagon, and it will cause the glycogenolysis and gluconeogenesis.
You haven't explained the reason for increase in insulin, increase in glucagon. This
sympathetic overdrive, that is the catecholamines will stimulate the pathway.
Yeah. Yeah. So catecholamine rise is because of the
HPA axis stimulation.
Axis. Very good. That's good. And these catecholamines will cause increase in
glucagon
and insulin.
Cortisol and insulin.
Yeah. So that's a very simple answer. I think I can give you, but still I'll give you a clear explanation. So sympathetic overdrive causing catecholamine surge and HP axis therefore causing increase in cortisol. And this catecholamine will have direct and indirect effects. So direct effect, both alpha and beta adrenergic receptors, it acts on it. An indirect effect only, if it is acting on the beta receptors, it increases both glucagon and insulin. If it is acting on both alpha and beta, it inhibits more of insulin than glucagon. So as a whole, the net result will be more of glucagon. So that's why there is increase in insulin as well as in glucagon. And yes, I think Sneha gets an score. But already Dr. Venu is on 3. So it will be -7 for Dr. Venu.
-5, ma'am. I think -2 my score.
Karthik?
Means, ma'am, this round it is -10, no?
Yeah, this round is -10 for Venu and plus.
Okay, if we do -10, then Venu will be on -7.
Yeah, okay. Now the second, so are you clear, Dr. Pratish? Can we move on?
Yes, ma'am.
Now, whom do you want to challenge this? No, you cannot challenge Dr. Venu.
Dr. Akansha.
You want to challenge on?
Ma'am, does Sneha gets any marks?
Yeah, +10 for Sneha. So, Pratish, whom do you want to challenge?
First participant, ma'am, Dr. Akansha.
Akansha. So, Akansha, are you ready to answer this next question? Akansha? Dr.
Yes.
Akansha? Yeah. Okay. A 45-year-old male is brought to the emergency department following RTA with severe head injury and respiratory failure. He is unconscious and has no spontaneous breathing. He's intubated for airway protection and ventilation, and correct placement of ETT is clinically confirmed. However, despite ventilation with 100% O2, there is no improvement in O2 saturation, and the patient continues to deteriorate. Now, this is the question. What are the 4 common reversible causes that should be immediately considered in this situation? See, you need to give a complete answer. Giving 1, 2, 3 will not fetch you any score. You have to give complete 4 answers.
Ma'am, one is either the placement of the ET tube is wrong, as in esophageal intubation could be one. Second is there is a pulmonary contusion or injury to lungs, which is why, or a pneumothorax, which is suppressing the lungs. A massive hemothorax could be one, which is again compressing the mediastinum, so compressing one lungs, oxygen saturation or increasing.
All comes to one. Next.
Immediate cause.
Okay, time is up. Now, again, Pritesh has to answer. It's on
Ma'am, 4H that we call hypoxia, hypovolemia, hypoelectrolytemia, or hydrogen ion excess acidosis. 4H according to ACLS. 4 reversible causes of
what are the 4 causes?
Failed resuscitation.
What are the 4 causes?
Hypovolemia due to blood loss, maybe internal or external. Hypoxia due to incorrect ET tube placement. Hydrogen ion excess may be due to underlying cell injury. That could be sepsis, acidosis, and hypokalemia or dyselectrolytemia, basically. 4 reversible causes of non-failed resuscitation.
Okay, like none of you get the score. I'll just give you the answer. So this is displacement, which was right. Obstruction, pneumothorax, and equipment failure. DOAC is a mnemonic. So these are the 4 reversible causes. So this round, -5 for Dr. Pritesh and -5 for Akansha. Okay. Next, Dr. Karthik.
I'll challenge
You want to challenge on whom?
Sneha.
Dr. Sneha. Dr. Karthik on. So, Sneha, are you ready?
Yes, ma'am.
Yeah. It's very easy. Name 4 non-abdominal based flaps for breast reconstruction. Time start.
The DIEP flap, the deep inferior epigastric. Then LD flap, latissimus dorsi.
Non-abdomen based.
This one?
Non-abdomen based.
Non-abdomen based.
Outside abdomen, think in terms of limbs. Lower limbs. Thighs. Glute.
Gluteal flap. Can we use gluteal and thigh flap?
Okay, time is up. Now, Dr. Karthik, you have to answer it with
gracilis flap.
Don't give tips for him. Dr. Karthik, it's your turn now.
Gluteal flap, LD flap, latissimus dorsi flap,
Again, on abdomen based.
latissimus dorsi,
Non-abdomen based. Latissimus dorsi is
and profunda artery.
but you're not come up with 4.
Gracilis flap.
Time up, ma'am.
Time up. Okay, that's time up. So these are the 4 flaps. Superior gluteal artery perforator flap, inferior gluteal artery perforator flaps. Got it? Superior and inferior gluteal artery. Gracilis, Dr. Sneha could have tried a bit more. She already came up with 3, only 1 more she left out, I guess. Profunda artery, more profunda artery perforator flap, PAP flap. Okay, so again, this is minus 5 for Karthik and minus 5 for Sneha. Now, Dr. Hazik,
Sure.
whom do you want to?
Who are left? Just want to know the names.
I think
Till now nominated are
Karthik, Pritesh. Who is left?
Venu, Akanksha, Sneha are nominated. Pritesh, Karthik, and Venu yet to nominate.
Oh, Venu got nominated.
Oh, yeah, sorry.
Only
Venu,
2 are
Akanksha, Sneha got nominated.
You can
Pritesh,
either
Karthik,
challenge on.
and Hazik.
I can challenge what?
Yeah, sorry. You can either challenge on Karthik or Pritesh.
Okay, so I'll challenge Dr. Karthik.
Karthik, okay. So Karthik, you need to answer this. A thyroid imaging, reporting and data system stratifies thyroid nodule characteristics into 5 risk levels from TR1 to TR5. And this is based on 5 feature dimensions of the nodule. Name at least 4. Your time starts now. Karthik?
Dimensions.
Dr. Karthik?
Ma'am, TR3 is more than 2 centimeters.
No, I'm not asking for TR1, 2, 3. I'm asking what are the features, parameters included on what basis TIRAT scoring is given? Feature dimensions of the nodule. TIRAT is based on the feature dimensions of the nodule. What are those dimensions? Dash of the nodule to be seen.
Cystic, spongiform, or solid.
That's what, yeah.
And
You need to give at least 4. Your time is already up.
hypoechoic or hypoechoic.
Time is already up. Right away, you give the answer. You don't have any time to think. If you want to think, then the question passes to the challenger. Okay, Dr. Hazik?
It is composition, echogenicity, shape, size, and margin.
Very good. So it's minus 10 for Karthik and plus 10 for Hazik. So composition, echogenicity, shape, margin, and echogenic foci. Based on the this 5 dimensions only, TIRAT scoring is given. Okay. Now the question goes to Dr. Venu. Venu?
Remaining candidates, ma'am. Remaining candidates.
Hazik and Pritesh.
Pritesh, ma'am.
Yeah. You want to challenge Pritesh?
Yes, ma'am.
Okay. Dr. Pritesh?
Yes, ma'am.
Yeah, ready. Yeah. A 10-year-old girl is brought to the OP with recurrent abdomen pain and occasional episodes of melena. Her mother also reported a history of similar complaints in her childhood, and she was found to have multiple gastrointestinal hamartomatous polyps on endoscopy, but did not undergo a definitive treatment. On examination, both mother and the child They had multiple hyperpigmented macules over the lips and buccal mucosa. Outline the long-term surveillance plan for the child as she transitioned into adulthood. So, your time starts.
It's Peutz-Jeghers syndrome.
Yeah, very good.
And colonoscopic surveillance will be started for this child.
The question here is outline the long-term surveillance. You get no points for diagnosis.
Colonoscopic surveillance.
Starting
And
with
also, ma'am, she has age of 25.
okay, any other next long-term?
25 years of age, and also screening for malignancies associated with Peutz-Jeghers syndrome,
What are those?
pancreatic malignancies, breast malignancies, and soft
See,
tissue
for
tumors.
breast, what will you do? For pancreas, what will you do?
Ma'am, mammography and tumor markers for pancreas, mammography for breast, self-examination for breast,
starting
colonoscopy
from
for
which age?
polyps. 25 years of age for 18 to 25 years of age.
For which surveillance?
Colonoscopy from 25 years of age, and mammogram would be started from early 18 years of age. Tumor markers can be done immediately at the diagnosis. We can rule out gross neoplastic etiologies immediately at the diagnosis. And colonoscopy at 25, breast mammography and self-breast examination. Self-breast examination can be started at diagnosis only. But mammography we can start by 18 to 21 years of age.
Okay, I'm quite satisfied with your answer, but let me see if Dr. Venu can give a more refined answer. If he's able to give more refined answer, then that I'll have to consider that. So, Dr. Venu?
Ma'am, upper endoscopy at the age of 9 years, upper endoscopy, and colonoscopy for the 15 years, and self-breast examination and mammography 30 years, and for pancreatic cancer, CECT abdomen 25.
Okay, then we'll go to the answer. I think I have to give it to Dr. Pritesh because he was quite close. So these are the associated malignancies, and this is the surveillance. See, mammogram MRI at the age of 30, and it should be repeated every 6 months. Colonoscopy at the age of 18.
18.
Upper endoscopy at the age of 18. And small bowel, again, all colonoscopies at 18. Pancreatic at the age of, it was like two of your answers, 3 answers of yours were right. And also pelvic examination, it to be done at the age of 20. An annual testicular examination if it's a male. Okay, so Dr. Venu, I hope you accept it, right?
Yes, ma'am.
Give it to Dr. Pritesh, yeah.
Yes, ma'am.
So Pritesh is getting plus 10, and it's again a minus 10 for Dr. Venu.
Yes, ma'am.
So no worries, you have rapid fire round.
Yes, ma'am.
Now, Dr. Akansha?
I'm Hazik.
Yeah, only left out is Dr. Hazik. Hazik, are you ready to answer?
Yes, ma'am.
So a patient presents with gallstone ileus. A plain abdomen film shows complete small bowel obstruction caused by a large radio-opaque gallstone obstructing the distal ileum. Now name any 4 signs of small bowel obstruction in the plain abdomen film taken in supine position. Your time starts now.
What, ma'am?
4 signs of small bowel obstruction in a plain abdomen film taken in a supine position.
In a supine position. This is, ma'am, regular stride.
Don't think of triad. You just answer this question alone. Any plain abdomen film taken in a supine position, what are the 4 signs of small bowel obstruction?
Step ladder pattern. This
Not
is what
only in this X-ray, in general you answer. Not only from this film. In general, any plain abdomen film taken in supine position, what are the 4 signs of small bowel obstruction?
4 signs of small bowel obstruction.
Yes.
This is step ladder. Yes, ma'am. Step ladder pattern. and then dilated bowel loose. It is more than, if it is more than 3 centimeters, 6 centimeter, or 9 centimeter, depending, 6 centimeter in cases of ileum.
Okay.
And small bowel obstruction. And then we have extra one I said step ladder pattern. One is dilated bowel loops, and
Dilated
then
centimeters, that is considered as one.
yes, ma'am. Dilated bowel loops, and one step ladder pattern.
Yeah, you have given
suggesting
two
of multiple
answers.
8-foot levels.
Hmm.
And then we have 4 signs I have to tell you.
Yeah. Choose anyone can answer. That's why I mentioned 4.
Okay.
Okay. Now moving on to Dr. Akansha.
Ma'am, peripheral dilatation of bowels in the periphery. Then, ma'am, no gas in the distal rectum or colon. Then, ma'am, string sign. Then, abrupt cutoff sign. And valvuli conniventis.
So finally is the 4.
Valvuli conniventis, dilated small bowel more than is it 3 centimeter in the periphery, no gas in the distal colon rectum, and cut
So
off.
So yes, dilated gas and fluid, you gave that. You gave, see, string sign, it's in the lateral decubitus position, not in the supine position. Absent rectal gas, you told. And peripheral dilated out, gasless abdomen, I think you gave only 3.
Dilated gas, the more than 4 centimeter, and small bowel.
Yeah, first one you
that
gave.
goes. And absence of rectal gas.
Did you told string sign? It's not string sign. It's stress sign.
I said string.
Yeah. So see, that's the difference it makes. It's in the supine position only. You
Air
should
fluid levels and valvuli conniventis.
all this comes in the upright position, lateral decubitus position. So it's not in the supine position. So it's -5 again for both of you. For Akansha and for whom? For Hazika. Yeah. So finally, this completes this round. Akansha's at the end of this round, Dr. Akansha has -10 and it's -20 for Venu, Dr. Venu, and for Dr. Hazik, it's +5 for Dr. Hazik, and for Dr. Karthik, it's -15. For Dr. Pritesh, it's +5, and for Dr. Sneha, it's again +5. Am I right, Karthik?
Ma'am, can you help me with the latest Akashas and Hazik's scores, ma'am? This
I'll just repeat it. It's -10 for Dr. Akansha.
Okay.
For Dr. Venu, it's -20.
Okay. Okay. Yes, ma'am.
And for Dr. Hazik, it's +5. So 5 points he has scored in this round.
Okay, ma'am.
For Dr. Karthik, it's -15.
Okay. Yes, ma'am.
And for Dr. Pritesh, it's +5. And Sneha also +5.
Yes, ma'am.
Okay. Now, at the end of all the 3 rounds, can you just tell how many scores each candidate has obtained?
At the end of round 3, Dr. Akanksha, her final score is 1.
Okay.
Dr. Venu is -17.
Okay, sir.
And Dr.
Hazik.
Hazik, he's on 15, if I'm not wrong. Yeah.
Yes.
And Dr. Karthik is on 6. Dr. Pritesh is on 24. Dr. Sneha is on 13. 1-3.
So all the best, and that I'm leaving on to Dr. Nandini, ma'am. All the best, and that will be the deciding round. Yeah. Thank you.
Yes, thank you.
Thank you, ma'am.
Thank you,
ma'am.
Dr. Nandini, ma'am.
Yeah, I'm here, right here. So we'll start with the rapid fire round. I'll just quickly elaborate on the rules. You'll have 6 set of questions, and each candidate will get 1 set. Okay, it is all randomized. So in each set, you have 10 questions, and each question carries 10 points. It's totally 100 points. Okay, so just be alert, but you'll have only 90 seconds to answer all the questions. Okay, there will not be any lenience of time. And after I read out the questions, the time will start. Okay, so it's a very simple round. No negative marking, no pass is there. You have to answer your whole set of questions. So let's decide the winner based on the rapid fire. You will have a very good chance to come ahead of others in rapid fire because there is no negative marking. You can just start trying to attempt all the questions. First, I'll like display the questions one by one. Then you will see the whole set of questions. So you can like change your answers, or you can reattempt answering any of the questions again also. That's not an issue. Okay, you got the, anybody is having any doubts in this round, rules and regulations?
No pass, ma'am. No pass.
No pass, no pass. You will get 10 questions, once each. There is set A, B, C, D, E, and F. Okay.
This is
Each,
last round, ma'am. This is last.
this is last round,
Okay,
which
okay.
gets to decide the winner of the day.
Okay.
Okay.
Ma'am, so if we don't want to
Yeah.
answer one question, so we'll just say
You don't
pass
have
and
to
we'll
answer.
skip
You
to
just
next
say
question.
pass. I'll go to the other questions. But
And
finally, I'll display all the questions where you'll have a chance of again attempting any of the questions if you want. And
so
I'll
the whole
calculate
questions will be on display all the time, like you will display one after the other on the same screen, or there will
one
be
by
separate
one will up.
screens?
Yeah, just a second. One by one will appear on the screen first initially. Then I'll display all the questions together. Okay, then so that it will be easy for you to go back to some question which you didn't answer first and which you might have to like remember the answer later also you can attempt. Okay, so this is just to decide on like how quickly your mind works. So this round is actually a bit easier round. There are no very weird things or uncommon things. All are like common things only. You'll get to know it when you like look at the questions. Can we start with Akanksha? You're ready, da? Okay. Okay, so we'll start with Akanksha. First, I'll read out the questions, then the timer will start. CT picture in this patient with bowel obstruction. If you want to answer, you can start answering also, ma.
Okay.
Stage this follicular C of size 4 centimeters with extrathyroidal extension in a 40-year-old with bony metastasis. What is SUMP syndrome, or where do you get SUMP syndrome? Most sensitive blood investigation in Zollinger-Ellison or gastrinomas.
Serum gastrin.
Yes?
And serum gastrin levels.
Okay. Other name for costocoracoid ligament in breast.
Halstead's ligament.
Yeah. MIVAT. Expand MIVAT. MIVAT.
Minimally invasive.
Okay. Bedness tumor. What is Bedness tumor?
No, pass.
Newer monoclonal antibodies used in IBD. Name anyone.
IBD. Ustekinumab.
Okay.
And,
Pathological subtype common in Black population in this pathology, in this condition.
acral lentiginous
Yeah, very good. Hatfield's cone excision. Where do you do it?
Dactectasia.
Okay, very good. You want to reattempt anything?
Stage, ma'am, bony mets in 45-year-old stage 2. No, stage. I'll go to stage 4.
Time's up, I think.
Stage 2, ma'am. Stage 2. Some syndrome you get in duodeno, choledochoduodenal anastomosis.
Okay, okay. That's all. That's all. That's all. Okay. So the first CT, no? They've shown. What is it? I mean, this is not for marks. Huh?
This is the world sign interception.
Yes. Where do you get it?
In interception.
Very good. It is interception. It's a classical sign. Bowel within the bowel. We had an ileocolic interception with the CT picture. Okay. You answered 7 questions, right? Okay, let's go ahead with the answers. So that is interception. Stage 2, complication of choledochordioidectomy. It's secretin-stimulated gastrin, Halsted ligament. It's minimally invasive video-assisted thyroidectomy. Bedner's tumor is a pigmented variant of dermatofibrosarcoma protuberans. Ustakainoma, we told it right. Acral lentiginous melanoma and ductaceae. So Akanksha gets 70 points in this round. Congrats, Tra. So we'll move on to the next candidate. You get set B. So your time starts now. It's 90 seconds.
Yes,
Dr.
ma'am.
Venu.
Yes, ma'am. Yes, sir.
Can we start?
Yes, sir. Yes.
Yeah, it's for Dr. Venu. Name the incision with modification, not just the incision.
Yes, Blades S modification incision.
Blades.
What
What is the modification?
Blades S modification. Yes,
Stage low-grade STS of size 15 centimeters, which is node negative.
Yes, pass, ma'am.
Classification to assign malignancy risk in this pathology. First, try to identify the pathology in an upper GI endoscopy.
Pass, ma'am. Pass, ma'am.
Hollander's insulin test.
Pass, ma'am. Pass, ma'am.
Name the triangle in a total thyroidectomy.
Base triangle, ma'am.
Okay. Dash, expand dash.
Dynamic ultrasonic of hernia.
Very good. Cannabis sign.
Pass, ma'am.
Pharmacotherapy for varicose veins. Any drugs you use in varicose veins?
Aspirin. Pass, ma'am.
No. Okay. Indian file or single file appearance in pathology?
Lobular carcinoma breast, ma'am.
Very good. Bronze anastomosis. What is a bronze anastomosis?
Bronze. Pass, ma'am. All display questions, ma'am.
Okay, yeah, sure.
Yes. Stage 15, stage 2B, ma'am. Second question. Stage 2.
Time's up.
Yes, ma'am.
Okay. So we'll go ahead with the answers. You've answered like 4 questions.
Yes, ma'am.
That incision is Bailey's modification of Black's incision. It is given in your Bailey.
Yes, ma'am.
All low-grade tumors in soft tissue sarcomas are stage 1 irrespective of the size.
Yes,
okay.
ma'am.
Any size, low-grade tumors are stage 1.
Yes,
That
ma'am.
It's a duodenal adenoma and assign malignancy risk in your spicification.
Yes, ma'am.
Okay, and whole intestinal of vagotomy, that's Behr's or Riddle's triangle. Canavi sinus in your DAS, venous hum louder on inspiration in portal hypertension patients.
Yes, ma'am.
Drug you give when varicose veins is flavonoids or pentoxifillin. It's there in Sabistance, FD or side to side jejanostomy is called as bronze anastomosis.
Yes,
so it's 40 points for Venu.
Yes, ma'am.
Okay. Yeah. We'll go.
Your voice is not audible clearly.
Nandini ma'am, I think.
Now, is it audible now?
Yeah, it's better now.
Yes.
I'll check with my. It's better now?
Yes.
Yeah, ma'am.
Can I start now or I'll wait?
I think you can start now.
Okay. Yeah, fine. So name the incision. Name the incision in breast.
Ma'am, it's not.
Stage this tumor with para-aortic nodes positive.
There's a lag, ma'am. I cannot see.
Stage the tumor with.
First question.
You're able to see or
No,
not?
ma'am.
Yeah. Is it visible or not, Hazik?
It's on the first slide, ma'am. Rapid fire. Yes, ma'am. First question, name of the incision. It's now visible.
Okay.
It's modified elliptical incision.
Stage the tumor with para-aortic nodes positive. First, look at the specimen. It's an high inguinal orchidectomy specimen. Stage the tumor if paraiotic nodes are positive. Stage.
Pass,
What
ma'am.
is Refitoff syndrome?
Pass, ma'am. Pass, ma'am. Pass. There's a lag, ma'am.
Phrase syndrome.
There's a lag, ma'am. I cannot hear you.
That just wait. What
Your
dietals?
voice is breaking in between.
Your net is not working.
Nandini ma'am.
Just a second.
Yeah.
Am I audible or not?
Now you are audible, ma'am. But in between, while you are speaking, we are unable to hear your voice.
Okay, my screen is visible now.
Yeah. Now it's better, ma'am.
Okay, I'll go ahead with the questions. The part in colonoscopy which has triangular folds of mucosa. Triangular folds.
What, ma'am?
Triangular folds of mucosa.
Pass, ma'am. Pass.
Dietals crisis. Where do you have this?
Sickle cell crisis. Sickle cell.
Okay. Read the X-ray.
Aplastic crisis.
No.
Ear under diaphragm perforation peritonitis.
What if what do we call it as when the X-ray is negative? I mean, when this X-ray is positive and the
Chilladity. Your voice is cracking, ma'am.
Ma'am, your voice is breaking. Ma'am,
there is plutonium, but lab. Yes. Of choice for in-moms.
Ma'am, can you repeat the question again? Because we completely lost your voice.
See or not? Yeah, I'm there.
Previous question.
Okay, drug of choice for pinworms.
Ma'am, previous question we didn't hear.
Previous question is answered.
Yes, answered. Okay.
Previous question is answered. Yes, answered.
Okay.
This one.
Yeah. Drug of choice for pinworms.
Pinworm, ivermectin, diethylcarbazine.
Hereditary pancreatitis mutations. Name any one mutation.
Hereditary pancreatitis. SPINK1.
Okay. What is Miles procedure?
Ask ma'am all the questions. Refitoff syndrome is basically a dyslectolemia which happens in the refeeding syndrome. And test to identify Frey syndrome. We check for dryness over the cheek area and angle of mandible. And detailed crisis seen in sickle cell crisis. And what else?
Okay,
Stage of
that's
tumor
all.
with yes, ma'am.
Okay, it's time's up. So name the incision. What is this incision? That is Orr's incision. Orr's incision. Obliquely, horizontally placed teardrop type of incision is Stewart's incision. And that one which I've shown in the picture is Orr's incision that you didn't answer. Stage the tumor with paraiotic nodes positive. Any CA testis with node positivity is stage 2. Distal mets is stage 3. If it is confined to the testis, it is stage 1. It is as simple as that. Refitoff syndrome is peripheral resistance to T4. It's given in Schwartz. Test to identify Frey syndrome. It's a very simple question. It is minus starch iodine test, where you will apply the starch and see. The part in colonoscopy which has triangular folds of mucosa is transverse colon. Where do you see dietals crisis? It's intermittent hydronephrosis in urinary calculi. That is called as dietals crisis. It's in Bailey. And X-ray with negative laparotomy, I mean X-ray with pneumoperitoneum, and when the laparotomy is negative, it's called as Chilaiditi syndrome. You answered. Drug of choice for pinworms is mebendazole. You have to know that as a surgeon. Hereditary pancreatitis, you answered it. It is PINK1. What is Miles procedure? It is nothing but abdominoperineal resection. It's given in Sabiston. So you get 20 points. Is my connection stable now? Yes. Otherwise, I'll just check with the connection and come back. Is it okay now?
Yeah, ma'am. Now it's fine. So he got 20 points, right, ma'am?
Yeah, Hazik gets 20 points. Now I'll move on to Karthik.
Ma'am, I think you should change your network, ma'am. Just check, ma'am. Ma'am, kindly check your network once again, ma'am.
So we'll start.
Ma'am, are you ma'am, am I audible?
Yeah.
Ma'am, I think
Okay,
just
okay,
check your
sure, sure.
network, ma'am, once.
Yeah, you're audible. I think.
We are
Okay,
unable to hear you, ma'am. Sorry for the inconvenience, doctors. Ma'am is joining in a minute.
Am I audible now?
Yes, ma'am.
Yes, ma'am.
Can we start?
Okay.
Name the incision. Stage the CA breast with T lesion of size 4 centimeters and ipsilateral mobile node.
T4D.
Just T and nodal staging alone.
T4.
ST4?
D.
Okay. Cambridge classification. Where do you use it? It's an endoscopic ultrasound based classification. Investigation of choice for GB dyskinesia. Other name for transversalis fascia. Expand Wi-Fi in chronic limb ischemia. It's given in Sabiston. Sky in the pie bladder. Where do you get this in trauma? Dual BRAF MEK inhibitor for metastatic melanoma or any BRAF inhibitor. Tumor markers in medullary CA other than calcitonin. It's very easy question. Buried dermal flap in lymphedema surgery. You know any of the surgeries in lymphedema? These are the questions. The time's up actually already. So we'll go ahead with the answers.
Cambridge classification of chronic pancreatitis.
Okay, yeah, that's right. It's chronic pancreatitis. Okay.
Transversalis fascia, 4 parts.
No. The time's up. The time's up. Okay. So it's Kreil's incision. It's T4B. And you said T for D. D or B? What did you say?
B,
You
B,
said D. Huh?
B, ma.
B only you said. Okay, that I'll take it as a right answer. Chronic pancreatitis is right. Investigation of choice for gallbladder diskinase SIDA scan. Okay, it's SIDA scan. Transversalis fascia, other name is endo-abdominal fascia. Wi-Fi is wound ischemia and foot infection. Pie in the sky bladder in prostatic urethral injury. Tramatinib dabrafenib combination is BRAF MEK inhibitor given for metastatic melanoma. You have to know this point. And tumor marker other than calcitonin is it's CEA. It's very easy. It's a better prognostic marker. Buried dermal flap is Thompson's. Okay. So you've answered 3 questions right and you get 30 marks. Next we'll move on to the next candidate. It is Pritesh.
Yes, ma'am.
Ma'am, how many marks should I give to Karthik?
30 marks.
30.
We'll start now. Your time starts now. Identify this huge submucosal tumor in upper GI endoscopy. This huge submucosal tumor. Okay. Resectability status of CA pancreas when the SMA is involved less than 180 degrees with contour irregularity. Whether it is resectable, borderline or unresectable.
Resectable.
Classification for benign breast disorders.
ND classification.
Okay, but there is a named classification. Cosyntrophin test.
Next.
Or rapid ACTH stimulation test. Where do we do it?
Rapid ACTH stimulation test, congenital adrenal hyperplasia.
That's wrong. Name the triangle. Okay. Name the triangle. It is in laparoscopic cholecystectomy. Where do you see cystic?
Hepatocystic triangle or Connard's triangle.
Yeah, it's hepatocystic triangle. Star in rectal prolapse. What is the expansion for star? It's given in. Okay. Bushclow-Weinstein tumor.
It's a carcinoma in situ penis.
Okay. Systemic drug given in intractable breast pain. The drug given in intractable cyclical mastalgia.
Evening primrose oil.
No. I asked systemic drug. Familial hypocalciuric hypercalcemia mutation.
HRPT2 gene or.
No. What is McVeigh's repair?
Femoral hernias repair. Repair for femoral hernia.
No. So your time's up. This huge submucosal tumor is leiomyoma. That is just, I'll take that as a right answer. When it is 180 degree, but when the vein is irregular, it is borderline resectable. It is not a resectable tumor. Classification for benign breast disorders is Page and DuPont classification. Rapid ACT stimulation test is for Addison's disease. Hepatocystic triangle was the right answer. It is not Calyx, it is hepatocystic triangle. Both are different. Star is staple transanal rectal resection. Bushclow-Weinstein tumor is not an in situ carcinoma. It's a giant condyloma accumulate of the anogenital region, usually in penis. Tamoxifen or ormeloxifene can be given in cyclical mastalgia. There is a tabular column in Bailey which you have to go through. Mutation in calcium sensor protein causes that. And McVeigh's repair is an inguinal hernia repair done using Cooper's ligament. What is femoral hernia repair? It's not McVeigh's, it is McEvidy's repair. That is different from McVeigh's repair. McVeigh's repair is given in Sabiston, okay, in hernia chapter. So you get 20 points, Pritesh. Now we'll go to Sneha. This is the last set of rapid fire. We'll start. Name the incision for this huge tumor. When you have huge tumors of phyllodes like this, what kind of incision you put? There is a named incision. Lymph nodal station along common hepatic artery. D-Meester scoring. Where do you use it? D-Meester scoring.
Pass.
Okay. Fecal inflammatory marker specific for IBD other than calprotectin. Identify this landmark which points towards the facial nerve. in a parotidectomy. It's triangular in shape. Okay, Tokyo consensus for acute cholecystitis. It has 3 components. Name any 2 components.
The local systemic information science and
Okay, Miami's criteria
for hyperparathyroidism.
Okay. Cetuximab is not given when this mutation is positive in CA colon. Highest risk in men to be is due to this mutation, where you have to do a thyroidectomy.
Red gene.
Red mutation, what codon?
634.
That is important.
634.
Let's see. Modification of lateral pancreaticojejunostomy. Name the modification. Named surgery it is.
Pass.
Okay. Your time's up actually. So we'll go ahead with the answers. It's Gaylord-Thomas submammary incision. It's given in Bailey. Station 8, 7 along the left gastric, 8 along the common hepatic artery, 9 along the celiac plexus. That is how we have to remember 7, 8, 9. DME stress scoring, I thought you might be easily able to answer. It is ambulatory pH monitoring in GERD scoring. Yeah, it's GERD. You could have just said GERD.
GERD.
Yeah, other than calprotectin, lactoferrin, it's given in Sabistin. It has the same sensitivity and specificity as calprotectin in diagnosing the inflammatory bowel disease. That is Conley's pointer. How can you miss this one? It points towards the facial nerve. I told you triangular.
Yes.
The triangular cartilaginous extension point. You would have assisted cases and seen it, no? Conley's pointer. Okay, it is Traeger or Conley's pointer. Tokyo consensus has local science, systemic science, and USG findings. Miami's criteria for completion of parathyroidectomy. Cetuximab is not given when there is KRAS mutation positive. Okay, KRAS mutation positive cases, wild type KRAS, you will not give cetuximab. Highest risk in there is recent ATA guideline says highest risk, high risk, and moderate risk. Based on it, you will do the thyroidectomy as soon as the baby is born in men's syndromes or within 1 year or even after 5 years. Okay, there are 3 categories. It's given in Sabistin: highest, high risk, and moderate risk. It's actually you have to know the mutations to solve your MCQs. Okay, so codon 918 T mutation, highest risk. Okay, what you said 630, what is it?
Yes,
That is high risk. That is high risk mutation.
high risk
Even it's difficult to memorize all that even for me, but you should be able to. That modification of the lateral pancreaticojejunostomy is Parrington-Rochelle modification of Piostos procedure. You have to know this. Piostos procedure is later. At least you could have said Piostos procedure. Okay. So I'll give you 20 points for answering local science and these things, Tokyo consensus, and for parathyroid. So Sneha gets 20 points totally. That's all. So Karthik, have you noted the points?
Yes, ma'am. I noted the points. Yes, ma'am.
Okay.
So
what
ma'am,
are we going to do? We're going to find out.
Sneha Agrawal points, ma'am.
20 points.
Okay. And the final scores are? Dr.
Actually,
Akanksha.
before that, there was a tough competition between Hazik, Pritesh, and Sneha, but all of them answered only 2 questions in rapid fire. Yeah. If one person has excelled even by 1 question, you could have changed the whole scenario in the rapid fire. That is the beauty of rapid fire. I actually thought all are one-line straightforward questions, and I thought it might be very easy to crack also. And I took it only from the systems, not even from general surgery, because systems are what? I mean, you'll be reading all the long cases, no case presentation. Those topics will be easier is what I felt. Okay, yeah. We'll announce the final scores.
Yes, ma'am. Dr. Akanksha Mishra is on top, ma'am, with 71. And Dr. Pritesh is in second position with 44. Then Dr. Karthik is in third position with 36. With a marginal 1 mark loss, Dr. Hazik in fourth position. and Dr. Sneha is in 5th position, and Dr. Venu is on 5th position, 6th position.
So first is
Dr.
Akanksha.
Akansha.
Yeah, actually, she answered 7 questions in the rapid fire. That with that only she came. I mean, she was on negative points, right? Before this round.
No, she was on 1.
No. One. Yeah, 1. 1 point, and now she has like come ahead of others because she answered questions well in rapid fire. Good, Akanksha. Okay. So she got first. And second one is
Dr. Pritesh.
Pritesh. Okay, congrats. So congrats to the and third one is Hazik, right?
No,
I'm right.
Dr. Karthik.
Oh, Karthik is third. Okay, okay. Well.
How many Dr. Karthik was having after round 3?
What?
Just
He's on 6, doctor.
At 20.
After round 3, Dr. Karthik is on 6. And he
No, he
answered
had
3.
24 points, right? After round 3.
Sorry, ma'am.
Karthik had 24 points, right? After round 3.
no, that
Pritesh had 24 points.
Oh, sorry. Yeah, Pritesh had 24 points. Yeah, Karthik only had 6 points.
Yes.
But he answered he answered one question extra. Yeah, he answered 30 questions. Okay. I mean, he got 30 points. Okay. So what are we gonna do, Karthik, next?
Done, ma'am. Done for the day, and congratulations to the winners, and everyone here are winners, and not to feel bad about losing. Very competitive. You guys have a very competitive spirit, and you guys have tried a lot. And wishing you all the best from DocTutorials, and I'll be reaching you out to individually, doctors.
Okay. Before winding up the session, can I get a quick feedback from the candidates? From each and every one of you.
Starting with Dr. Sneha.
Yeah, starting with Sneha.
I like that round of the pictures. It was the most interesting and very unique round. And overall, also, the questions were very nice. Thank you.
Okay. That's all? Okay. Next.
Dr. Hazik.
Yes. First of all, I would like to thank both the faculty members for taking time for us and curating such a brainstorming all the 4 rounds. And probably round 1 was my favorite because it had a lot of brainstorming.
Which one? I didn't
Round
listen.
1.
Okay, round 1. Yeah. Thank you. Okay, what about Dr.
Nandini? This is excellent, ma'am. That one is Vaisakhi madam that conducted AI pictures. That is more confusing.
It's confusing. Okay.
Remaining
Nice.
all ma'am 3 rounds, ma'am. Good.
Okay.
Yes.
Okay.
Dr. Karthik. Dr. Karthik, you are on mute.
Very well framed questions. It tested our knowledge. I was now I know where I'm lacking and all. So thank
Yeah,
you.
that is the whole point.
Good point.
Yeah, good point. Akanksha?
Okay, Dr. Akansha.
Ma'am, very, very well structured questions. All of the rounds were very different from each other, and all of them actually sort of highlighted a different characteristic. Like some were memory based, some were more of what do you follow in your ward rounds, and all of that. And most of them are very much related to the NEET SS topics that are actually very high yield. So I think all of it was very, very good.
Okay. Ritesh?
Ma'am, I'd like to thank both of the faculties and Dr. Karthik for the time and energy that they've put in. And this was a wonderful experience for me, and I enjoyed a lot. Thank you so much.
Okay. So basically, the first round, I thought all the clinical scenarios, I made it like that because I don't want you guys just to be reading and cracking the MCQs all the time. You should also know how to apply all those points when you're like diagnosing, evaluating, and treating the patients. For that only you're reading, right? Not just to crack the MCQ. So that's how I made those rounds. All those were actual scenarios which we faced, and all those were real authentic videos of our all patients. Okay. So rapid fire, I made it like some of the things which you have to remember for SS exam and which you have to memorize. There is no other choice. Okay, maybe it will be helpful somewhere when you're cracking an MCQ or something like that. And obviously, rapid fire will usually have lots of eponyms and named classifications. That's how it was. And some useful pictures were also there. Okay. Okay. Dr. Vikasini ma'am is
Ma'am
there?
is not there, ma'am. She had
Ma'am is
some
not there.
emergency. She has to leave.
Yeah, that's okay. That's okay. Okay, so I thank you all. And if you want to like if you want to like follow, I mean, if you want to get to know any of these questions, I'll be usually posting so many questions in my Insta page. Okay, so you can follow me on my Insta. I'll be regularly posting some of the questions like this, clinical scenarios, pictures, interesting videos, and all in my Insta page. Thank you so much.
Hello, ma'am.
Thank you.
Thank
Thank you
you.
so
Ma'am,
much, ma'am.
can you share the PPT slides for the questions in our group?
Yeah. Sure. We'll share it later. Yeah,
Thank
sure.
you.
Yeah.
Thank you.
Thank you.
Thank you, everyone. Wishing you all the best.
Thank you, sir.
Thank you, ma'am.
Thank you, sir.
Thank you, Nandini, ma'am. Thank you so much.
Bye.
Thank you,
Yeah.
Vikashini, ma'am.
All the best. All the best to every one of you. Bye.
Thank you.
Bye.
Thank you, ma'am.